Hi, I'm Vasil, and today I'll be talking about sex, ethnic, and age-specific centile curves for DXA-derived measures of BMC and ABMD in white and Asian Canadian youth. Now that's a mouthful, so let's start by breaking it down with what we mean about bone. So when we're talking about bone, we're talking about bone mineral content, or BMC, which is the crystallized mineral in an image section of bone, and areal bone mineral density, or ABMD, which is the bone mineral content per centimeter squared. We use dual X-ray absorptiometry to measure this, and that's a special X-ray machine that measures the density of various bodily tissues, such as bone at the total body less head, lumbar spine, total hip, and femoral neck sites. So bone differs on a number of factors, including sex. Males typically have more bone mineral density than females. Race, Black people have higher bone mineral density than white people, have higher bone mineral density than Asian people, and age. So the older / more mature you are, the more bone you're going to have. So the red rectangle shows the approximate age range of our participants in the study. So you can see that a lot of bone growth is happening during this time. Centiles, for those who aren't familiar, are basically growth charts showing how individuals compare to other individuals of their same sex and age. So for example, a 3-year-old girl who weighs 36 kilograms is heavier than around 75% of her peers. These centiles also exist for bone. They, however, only exist currently for Black and white populations. So we know that Black and white populations typically have higher bone mineral density than Asian populations. And when we're comparing Asian populations on scales that really aren't meant for them, we risk missing diagnoses such as low bone mineral density. Therefore, the objective of our study is to develop sex, ethnic, site, and age-specific lambda, mu, sigma, or LMS values, and centile curves for bone outcomes in Asian and white youth. So we had 954 participants with 4,752 observations from the Healthy Bones Study 3, which is a 11-year longitudinal study. Our participants were 9 to 23 years old, and they were healthy children, adolescents, and adults, with 52.5% of the participants being Asian. We used DXA imaging for all those sites that I mentioned before: total body less head, lumbar spine, femoral neck, and total hip. And we used LMS Chartmaker Lite, which is a standard LMS creation tool that allows us to create LMS values and centiles values. And we did all of our graphical formatting in R. So the LMS method was developed by Cole and colleagues. And basically, L, or lambda, is the power transformation. So that's an exponent that is applied to the whole data set to help it better resemble a normal distribution. The M value, which is the median, and the S value, which is the coefficient of variation of the data set. So all these values can then be plugged into this z-score formula, and this allows us to get a z-score for all the bone values. Z-scores, for those who aren't familiar, is how far away, how many standard deviations away you are from the mean. And so when we're talking about bone, 2 standard deviations away from the mean is considered low bone mineral density. So in our results, you see the 3rd, 10th, 25th, 50th, 75th, 90th, and 97th percentiles. Here we have Asian boys and Asian girls. All the charts I'm presenting today are for total body less head bone mineral content. So when we compare Asian boys to white boys, we see that white boys have higher bone mineral content than Asian boys. We also see that white girls have higher bone mineral content than Asian girls, although this one is a little bit harder to see. But you can see that here, for even the 10th percentile of Asian girls, they are still lower than the 3rd percentile of white girls. So why do we care about this? Basically, it allows researchers to now include Asian populations in their height-adjusted z-score calculations, as well as allowing clinicians to use DXA to determine low bone mineral density with more specificity to Asian populations, as they're able to do for white and Black populations currently. Our study is obviously not without limitations. Asian is a pretty broad term. It doesn't include more specific ethnic groups, and it also doesn't include other ethnicities, so more research needs to be done into, for example, Indigenous populations. Centile curves also do not consider maturity, so researchers have to include that as another variable in their analyses. I'd like to acknowledge my supervisor, Dr. Lee Gable, and the Movement and Musculoskeletal Health Lab, as well as the lab team, and especially to the HBS3 study and investigator, Dr. Heather McKay, for providing the data for the study. These are my references. Thank you.